Hi, I'm Nick Carson, System Trainer for BJC Behavioral Health in St. Louis. As all of you know, there's been a lot of confusion surrounding the implementation of evaluation and management codes for psychiatry. Much of the terminology used to determine the correct code number may not be so straightforward. My purpose is not to make you the best coder in the world, but rather ensure that your documentation supports the service that you provided. The greater purpose of E&M coding is to demonstrate the medical necessity of the appointment. Today we're going to examine the elements that are used to determine the correct E&M code number for established follow-up visits. I'll let your excitement settle. For the next few minutes, I want you to forget everything you learned in medical school regarding documentation to avoid any confusion. From a coder and auditor's perspective, there are three components that are used to determine the correct E&M code number. Those are history, examination, and medical decision-making. Medical decision-making? What the heck is that? You don't need to master the coder's terminology. Instead, be aware of the concepts. Of these three components, you must meet or exceed the requirements for any two for follow-up appointments. As physicians, history and examination are items with which you're familiar, so let's start there. History begins with the chief complaint, which is the reason for the visit, is required for every visit, and should be clearly stated. Neglecting to include the chief complaint will result in a denial of payment. History is then broken into three subcategories: interim history or history of present illness, which is composed of 8 elements, past family and social history, as well as review of systems, which contains 14 systems. 1 point is assigned for each section and negatives are admissible. Reference your E&M guide for a detailed understanding of the ranking. Next is examination. This is the simplest to assess. It's all about bullets. There are 15 possible examination elements. The amount you address will determine the examination type. Finally, there's medical decision-making. Now, I know this term was never discussed in medical school, but medical decision-making is composed of 3 sections: risk, problem or diagnosis points, and data points. You only need to meet or exceed requirements for any 2 of these. Again, reference your E&M guide to determine the problem and data points. The level of risk is determined by choosing the highest level achieved for any column. For follow-up appointments, there are 5 possible E&M codes: 99211, 12, 13, 14, and 15. As I mentioned before, of these 3 components, you must meet or exceed the requirements for any 2 for follow-up appointments. That means if I have a detailed history, expanded problem-focused exam, and moderate medical decision-making, my code should be 99214. Okay, so let's give it a try. You've gathered a detailed history, problem-focused examination, and medical decision-making is low. What code should you choose? That's right, a 99213. Let's take a closer look at the requirements for each code. Starting with a 99211, you'll see that there are probably no situations where you would bill a 99211. You don't even have to see the patient. Even a 99212 would be unusual for the SMI population in the CPR program, unless your visit is limited to giving ibuprofen for a simple headache or antihistamine for an allergy with no attention to psychiatric illness. If you're providing management for the psychiatric illness alone, you'll typically have at least 6 bullets, which places you in the expanded problem-focused category, closer to a 99213. A 99213 does occur for some brief office visits with patients with SMI in community mental health settings, although it would not be typical. It might occur in a refill-only visit where there's no psychological, relational, social, financial, housing, case management, or biological issues to discuss. At 9 exam elements and above, you enter the detailed exam category, closer to 99214 and 99215. In fact, most coding for patients with SMI will fall between the 99214 and 99215 due to the complexity and life effects of the patient's illness and necessary interventions for them. 99215s would be particularly common for those CPR patients who are also in the healthcare home program. A 99215 is used for the highest level of medical necessity, but will still occur regularly. For a highly integrated setting with many ill patients and multiple illnesses to discuss, it may even occur frequently. As you can see, coding is complex. But despite this, there's a simple rule that you can follow. Focus on the patient and be thorough in your documentation. Remember that the greater purpose of E&M coding is to demonstrate the medical necessity of the appointment. Documentation of what occurred is key. Do not rely on how easy you found the appointment. E&M coding captures the complexity of what's required from the physician, not how comfortable you are with providing it. To make things easier on you and your staff, keep a guide handy to help you decipher the elements that were addressed during the appointment and improve your accuracy with choosing the correct code. I know with practice you'll be as comfortable choosing a code number as you are with providing treatment. Thanks for your time today, and have a great one.